am delighted to be able to talk to you about this because I think it's tremendously important. And I guess very fundamentally, the question speaks to what is the cause of Parkinson's disease? Is it genetic or, as usual, the very oversimplistic dichotomy or paradigm of genetic or environmental? And we're all aware of the revolution in molecular genetics, but I guess fundamentally, again, I have a background concern that the cause of most sporadic Parkinson's disease may not be clearly genetic. So a critical issue is that Parkinson's can be quite neatly divided between young onset, and again, that's an arbitrary definition, but it could be under the age of 50, and more typical sporadic. And the average age of onset of Parkinson's disease seems to vary quite a bit, as you could imagine. Some studies say it's as old as 70. Most would say in the early 60s, perhaps. And the fundamental concern is the seemingly kind of inevitable train of causation between I found a gene, a biotech company finds a product, the shareholders are happy, and those implications which are hugely cost related, and frequently one sees articles referring to precision medicine in Parkinson's disease, a new era that has arrived, that genes are as common as 20% of the Parkinson's population. And these statements appear to be made with great frequency, but I think their underpinnings are not particularly robust. And however you define precision medicine, and I don't think it's defined as doing an extensive genetic search and maybe identifying a variant of uncertain whose role in the causation of Parkinson's is uncertain. So my particular problem is an interesting one, perhaps, for the year 2023 in terms of how much genetic knowledge should a patient be allowed? And you might say that's ridiculous. Everybody is entitled to know about their own body. It's their own concern. But there's a very long history, and the general model, as we all know, is that of Huntington's disease, where careful genetic counseling is the correct method of diagnosis, and over the counter, if you want, genetic diagnosis is basically for many countries, if not frankly illegal, generally very much frowned upon. And there are well-established guidelines for this. And for example, guidelines for testing the ApoE4 allele in Alzheimer's disease were published in 2011. And they said the same general trend as with Huntington's. Direct-to-consumer genetic testing is not a good idea, and that in general, testing for risk factors, particularly if there's no clear treatment, and of course we know that in Alzheimer's there are now potential treatments, potentially available to some people. So the Alzheimer's world has changed a little bit, but it directly applies to Parkinson's. So we can predict again, it's no longer a revolution because it's been ongoing, the massive amount of work that happens in molecular genetics. Every few weeks or few months, there will be new variants described for various genes associated with Parkinson's disease, for example. How important those are, I think, remains to be determined. So there are also problems, inevitably, that the numbers tend to be relatively small, and therefore the predictive capacity of genetic testing for a particular patient is perhaps relatively poor. I think this is a very important area of research, using genetic testing or genetic profiles for trying to determine the prognosis of a patient, but I think it's a very difficult one. So if I can do my best to sum up, I would try and draw a line in the sand and say, first off, everybody needs to get together to decide how should we go about genetic testing in 2023. Should it be the traditional method of you physically sit with a genetic counselor, or can that be done virtually? Should it be that you counsel everybody before the test, the standard Huntington's approach, or, as seems to happen, you test a lot of people, and in those where there's an abnormality, you offer them counseling. As you can tell, I personally think that's perhaps a bad idea, but I'd like to stress I'm just a general neurologist, and I think this is the field requiring expertise of genetic counselors. But I think it would be very beneficial to the Parkinson's community for genetic counselors to perhaps publish appropriate guidelines for our current time. And then in general, genetic mutations causing sporadic Parkinson's disease are quite uncommon. The exception is clearly variants in the GBA, and those vary quite a lot by ethnicity. So as with LRRK2, where LRRK2 is very common in Ashkenazi Jews, so too GBA variants are probably commonest in Ashkenazi Jews, but they're certainly found frequently in Northern European populations, and probably less commonly in Asian people of Asian ancestry and people of African ancestry. So one needs to be careful in a small planet of making statements that might apply only to one particular ethnic group, when they certainly don't apply to other ethnic groups. And fundamentally, we sit with the problem of, as I'm speaking to you, there is no treatment of genetic abnormalities in Parkinson's disease. And there may be many drugs in the pipeline, but a pipeline is a pipeline. All drugs need to be tested. So that is the fundamental problem, as with Huntington's disease, in terms of genetic testing. If there is no treatment, genetic testing becomes much more difficult to proceed with.